So I'm going to be talking about stenting sleeve gastrectomy leaks. These are my disclosures. So sleeve gastrectomy leaks, despite all of our best efforts not to have any leaks, it occurs about to 1 to 5% of patients. And how we manage that leak ultimately depends on a few factors. When we diagnose that, the size of the leak, whether the patient has peritonitis, and what their hemodynamic status is. Obviously, if they are unstable or they have evidence of peritonitis, sometimes surgical management is necessary, but we're going to be talking about endoscopic management today. So in terms of stents, there's many different stents available. Stents have been traditionally used for the management of strictures, but we're going to be talking about using them in leaks management. So stents allow for the closure of large defect leaks and fistulas. The reason that is because, as you can see, they're quite long. They can completely exclude the area, the defect and the leak. The first description of this was in 2007, particularly for bariatric surgery, so not just sleeve gastrectomies, but also Roux-en-Y gastric bypass and duodenal switches. And in this study, they did notice that there was an 81% success rate in the closure of leaks. Because of that, ever since then, it's been one of the most common modalities used for the early postoperative period. So in this instance, obviously, because you want to exclude the defect, generally partially or fully covered stents are used. There's also now bariatric-specific stents, so not just the ones used for esophageal strictures, but also different companies that have made longer stents, as you can see here. The longer stents allow for coverage of the incisura, allowing for making sure that there's no distal obstruction present, and it allows for the stent to be in a proper position. And you can see here, different stent companies make different ways to help fixate the stent. So you can see on the bottom, there's some migration cuffs to prevent migration. Excluding the leak is not the only thing that you need to do in terms of managing leaks. You do need to make sure that you have source control, so you need to drain the abscess cavity, sometimes with drains. You will need to make sure that there's no distal obstruction. The stent is good for that because it helps to keep things open. So you need to make sure that there's no evidence of obstruction. And you want to make sure that with any fistula tract is not epithelialized, so it allows for adequate healing. So you do want healthy granulation tissue present if possible. So I'm just going to talk about the different types of stents that are present. The ones that we mostly use are fully covered metal stents. As you can see here, they're fully covered with either a silicone or polyurethane derivative. The reason this is helpful is that it prevents any extravasation of any ingested contents. It allows for patients to start eating almost immediately. The covering doesn't allow any embedding of the stent into the tissue, so it prevents any tissue ingrowth. So it allows, it's easy to remove both endoscopically and fluoroscopically. Because of that, there's no adequate fixation sometimes, so it's a little bit more prone to migration. There are ways that we can help to fixate the stent, either with clips or by suturing. These are just examples of partially covered stents. As you can see here, they're a little bit different in the sense that the proximal and distal flanges are uncovered. This allows to reduce the risk of stent migration by having the tissue be able to ingrow in the stent. However, as you can see, that makes it a little bit more difficult to remove at times. The other risk is that because the proximal end is uncovered, you can have an ongoing leak at the proximal end. So this is one of the risks of using partially covered stents. This is Dr. Pauli's graciously gave me a video to show here of how a stent is deployed. You can run the video for me. So as I mentioned, this is a patient that has a sleeve gastrectomy leak. As you can see, there's an air fluid collection outside of the sleeve. Drains were placed laparoscopically, and you can see here in the endoscopic view that there are JB drains that you can see showing the large defect. This is where the stents are the most useful, is in large size defects that sometimes other modalities are not able to cover. As you can see here, there's a large abscess cavity. All right, so when a stent was deployed, you can see that there's an ongoing leak after this with a sort of like a endoscopic upper GI. You can see there's a persistent leak. So a second stent was then deployed. So this is how it's useful to use fluoroscopy during your procedures, is that you can see if if there's adequate coverage of the stent, see if there's ongoing leak while you're doing the procedure, that you can ultimately do something about it at the time of your index procedure. So you can see that the stent is not in the quite proper position, so the stent was repositioned. As I mentioned before, you do want to place your guide wire past the pylorus so it allows for adequate positioning. And then you can use this to place another stent. And you can do a stent within stent. So this allows for adequate coverage of your defect, particularly if it is long. Then you can use a stent within a stent in this instance. So when you do deploy the stents, you do want to do them under fluoroscopic guidance. It allows you to sort of ensure proper positioning while you're doing that. And this is just showing how the stent is deployed. So the stent is loaded over the guide wire, and then you can use the fluoroscopy to make sure that the proximal and distal landing zones are appropriate.
Thank you very much.
Thank you.
All right. Next.